Picking up where we left off with typical antipsychotics that give common side effects, we're going to go on to atypical antipsychotics. So what we're going to be noticing with chlorpromazine is that we're going to see an expansion in this ring structure in the middle, and an addition of a nitrogen. And with haloperidol, we're going to be seeing all sorts of changes where this ketone may change, an addition of a chloro group here, and other additions may happen. Clozapine being the first atypical antipsychotic, meaning that it gives different side effects such as dyskinesia, which is kind of odder movements. So maybe like if you have Parkinson's, you'll have some sort of dyskinesia, or maybe orthostatic hypotension. Clozapine, as I said earlier, is going to have this 7-membered system in the middle and an added nitrogen. We also see a piperazine ring addition, which helps cross the blood-brain barrier. We're going to end up seeing this addition for aripiprazole. Risperidone and ziprasidone, similar to haloperidol, have this electron withdrawing group, but the electron withdrawing group in ziprasidone is in a different place. We also see that the ketone is gone, but this alkyl group still decreases the affinity. For olanzapine and ketapine, which are similar to clozapine, still have that 7-membered expanded system and a piperazine ring. The one difference for ketapine is that this sulfide here would increase affinity as seen before. All of them which still contain the benzene ring, which is important for van der Waals interaction, the nitrogen-containing group that will become dealkylated for a protonatable nitrogen for the dopamine receptor binding site. The SAR for aripiprazole becomes the aryl-piperazine quinoline, the aryl ring being important for van der Waals, the piperazine being important for crossing the blood-brain barrier, the middle alkyl chain that later becomes attacked on for aripiprazole for decreasing the potency, having a more flat hydrophobic area, which is the aryl halide, and we have that continuation of the protonatable nitrogen. Later on, when we get to clinicals in schizophrenia, we see that they use a PANSS positive scale, which explains the emotional or actions of behavior. And we also see the PANSS negative subscale. We have hallucinations inside the positive, excitement, grandiosity, and for the negative, we have emotional withdrawal, poor rapport, or maybe difficulty in abstract thinking. Thinking back on my childhood when my dad was taking Abilify, I thought it was kind of funny to see that I've seen these in action. When he would be taking Abilify, he would have hallucinations, but he would be more lively and attentive to you. But as he was doing or considering a potential conspiracy theory of why not to take Abilify, then he would have a lot of withdrawal because of the voices he was hearing. All of these clinical trials that were administered did show that the positive subscale did increase with administration of aripiprazole, with the 3 administering doses as located right here, the 10 to 20 milligram for the first trial, 20 to 30 milligram for the second trial, and 20 milligram finally for the last trial. All of them administered with placebos, and the placebo showed that there was a negative subscale increase. For all of these trials, it was shown that there was no change for ages and for sex, also for race. What I did notice that was interesting is that there was an 8% earlier that was notated of the white population that had a poor metabolism. They said here that there's no change in race. I would consider that a change, but maybe it's so small that it could be negligible for people who are schizophrenic. As for bipolar mania, the way that they had administered and monitored aripiprazole usage is the Young Mania Rating Scale, which is the irritability, the disruptiveness, or maybe increased activity of sexual interest. We were wanting to decrease all of these manic rates. But for administering aripiprazole, we saw that all of these decreased, no responses to age and gender. Other ways of, or other aripiprazole derivative drugs, we have Abilify Maintina, which is a 1 month injection, or once a month injection, and it is the same drug as aripiprazole. The aripiprazole Laroxil is another injection, also known as Aristata. It's longer lasting. The only thing that's different, it still has this arylpiperazine quinoline derivative. It has a longer chain right here. I assume that keeps it active inside of the body longer, so it has a longer excretion time. Thank you.